Rotary International's areas of focus, excuse me, education and saving mothers and children, with emphasis on saving children. It's a pleasure to introduce our speaker, our very own Dr. John Dunne, to address the challenges and solutions around mental health. As I mentioned, two-part series, and Dr. Budd will be doing the second part on October 26th. Dr. John Dunne has been a member of the club since 2015. He and his wife Joy moved to Bellingham in 2014 after living in Seattle for 41 years. He trained in both general and child psychiatry at the University of Washington's hospitals, following which he went into private practice in 1977. Throughout his career, he has been active in professional organizations and issues. In 1979, he organized and was the first president of the Washington State Council of Child and Adolescent Psychiatry. He has held all of the elected offices in this association, including president. He was honored with the Catcher in the Rye Award, the highest honor of the American Academy of Child and Adolescent Psychiatry. Closer to home, he was one of four authors of the Parenting Act of 1987, which fundamentally changed the divorce law and the legal responsibilities of unwed parents in Washington, a change that has been adopted by at least 32 states. John, thank you in advance for sharing your insights in this especially important issue in our society. Gary, if you'll give John presentation rights, and John, you have the floor.
Thank you, Gary, for that introduction. As you mentioned, this is the first of two parts, and Dr. Vanna is going to be giving us a second part 2 weeks from now. But I really appreciate you being here. It's nice to know that you have a little bit of extra time to come and join in and hear what I have to say. There's a lot to cover here, and I probably will sound like I'm kind of speeding through a lot of things, but it's a chronic, long-standing problem here. Okay, let's get this up. Share, okay, I got it. Here we go. Okay. I need to get up the slide. There's the slideshow. Okay. This is a long-standing chronic problem, and unfortunately, it's really not specific to Washington. These kind of difficulties are pervasive throughout the country. Looking statistically, we are kind of average. There are some states actually that are doing better than us, but quite a few that are doing worse. This really came to public attention in 2018 because of a crisis at Western State Hospital when they lost their Medicare accreditation in 2018. This created an enormous hole in their budget, which of course had to be filled by the state. But Medicare, the Center for Medicare and Medicaid Services have been warning Western State for a long time that they need to clean up their act because of their high rates of assaults and injury to their staff. And really nothing changed over this period of time, and they finally kind of gave up and threw in the towel in 2018. But there had been chronic underfunding by the legislature, and that led to inadequate staffing, requiring excessive overtime and double shifts, leading, of course, to low morale and frequent turnover. They have a very volatile patient population of both civilly and forensically committed patients, and the civilly committed patients are those who have committed crimes but are considered too volatile and dangerous to be housed up at Monroe. And part of this has been exacerbated by the unsafe physical layout, which was designed in the 1930s. And back in the 1930s, this building, set of buildings actually, were constructed to house about 3,000 people who were kind of chronically mentally ill, but generally fairly stable. I mean, we might think of this as a long-term residential facility. And it really was not set up for the kind of population that we have today. So let's take a look at the scope of the problem currently. And I want to put up this little piece of information, the 2.32% of the US population in Washington. And I use this because this is the metric that I use to convert national statistics to Washington statistics, which admittedly is a pretty crude measure, but it's the best I could do because I couldn't find specific Washington statistics. So we have roughly somewhere between 19 and 51,000 Washington residents with schizophrenia, about 213,000 with bipolar disorder, and 259 with major depressive disorders. Now, these three really constitute the major source of chronic disability for mental illness worldwide. So I wanted to kind of note this discrepancy. For Black and Latino populations, it's substantially higher rates of psychotic episodes than whites or Asians. Now, some of this is probably related to the higher use of illicit substances and alcohol, but it's also related to their social marginalization, their poverty, and lack of access to good medical and psychiatric care. The other thing to note about these statistics is that about a third of these psychotic episodes do not create distress in the people experiencing them. And they also don't necessarily represent psychiatric illness. So they can occur in stressful situations of various sorts. So let's look at the deaths kind of related just as a mode of comparison. So opioid deaths in 2018, somewhat more than 1,000 in Washington. And as our President Kerry has repeatedly noted, this is likely to be substantially more during our pandemic year. Suicide likely will go up also. It was estimated, I'm estimating about somewhat more than 1,000 that based on statistics from 2018. Now here's an interesting comparison. So there were roughly 923 Washington deaths related to gun fatalities. However, because 60% of these are related to suicide, only about somewhere in the neighborhood of 370 of these deaths were actually homicides, law enforcement related fatalities, or accidental deaths related to firearms. So even though homicides gets a great deal of publicity and suicides much, much less, it actually is a much smaller part of the difficulty. So for comparison, there were only about 900 Washington auto fatalities. And taking a look at public health resources, Western State Hospital has 806 beds. Now remember that it was built for 3,000, but it's been condensed down to these 806, of which 350 were forensic cases. Now these are people who are too violent to be at Western State Hospital, or they're there waiting to see if they are mentally competent to stand trial. Eastern State Hospital has 125 forensic cases, the rest for civilly committed. McNeil Island has 228 beds for the sexual offenders. Child Study and Treatment has 47 beds for older children and adolescents. Harborview has 66 beds for psychiatric and substance abuse. These are, of course, all adult beds. Monroe State Prison has a psychiatric unit for substance abuse and sex offenders, although I could not find information on exactly the number of beds that they have available for that. There are also 2 Veterans Affairs hospitals And again, I could not find specific bed information for that. There are other resources, both inpatient and outpatient. There are private non-profit community psychiatric units scattered throughout the state, including St. Joseph's, which has 21 beds. There are a few for-profit psychiatric hospitals. The closest is down at the Smoky Point Behavioral Hospital, and I will note that it has, in its relatively short life, garnered a substantial reputation for substandard care. There are a few halfway residential housing programs for the chronically mentally ill. One of these just hit the paper today, down in Seattle. A 60-bed residential unit is closing because of decrepit facilities. Much of the outpatient care is provided by community mental health centers such as Compass, or nonprofit community mental health providers such as Catholic Community Center or Unity Care here in Bellingham. There are high rates of turnover in these community health settings and other nonprofits, and this is really largely because of poor reimbursement for services by Medicare and Medicaid. And even though there are a substantial number of private practice mental health providers, all types that generally do not accept Medicare or Medicaid because of the low reimbursement. There's a definite unequal distribution of human resources, both urban versus the rural. And interestingly, we are doing much better than most places outside of the Bellevue, Seattle area. We actually have a pretty good set of resources in our both community and private practice providers, even though if anybody who has tried to access these services, you know that they are in short supply. So from a historical perspective, I'm going to kind of run through this, but originally there really were no hospitals either for medical care or for psychiatric care. There were almshouses, which we imported from Europe, and these were really very dismal places where the insane were generally kept in cells, and the more agitated ones were kept in chains. Sanitation and nutrition were terrible, and that led to a rise in the early 19th century by the Friends Church in Philadelphia for what was called moral treatment. This is basically humane treatment. So treating people who were insane as people and individuals was really their aim. And this really, I think, should be thought of as more like a long-term care facility we now have for elderly, since it was primarily, in fact, it was solely populated by members of the Friends Church, all who were lay people. There were no medical care. In the middle of the century, Dorothea Dix campaigned for states to take responsibility for the indigent, both medical and the psychiatric, and that led to the establishment of psychiatric hospitals in the states. So the Insane Asylum of Washington Territory was established in 1871. Interestingly, this was 7 years before the precursor to Harborview Medical Center was established. Now, what happened was that physicians in the community quickly learned that they could dump patients with dementia into the insane asylum, but it was never given extra funding by the state. So by the end of the century, these had become really almost as bad as the almshouses. So in the 20th century, things did improve. There was an emergence of psychiatry, psychology, mental health counseling, and interestingly, occupational therapy as specialties in mental health care. And I mentioned occupational therapy in particular because during the first half of the 20th century, occupational therapy was considered the main resource for providing treatment to the chronically mentally ill. Thorazine was the first effective antipsychotic, which was introduced in the mid-1950s. Unfortunately, although it was effective, what it did is it led to a rapid fall in the hospital census. They treated people, they got better, and then they sent them out in the community, but there was no outpatient system to care for these folks, and they quickly fell out of maintaining their treatment. And I will say that taking Thorazine is a pretty unpleasant experience. And frankly, if I was psychotic back in those days, I probably wouldn't have wanted to continue it either. But at any rate, it led to this revolving door situation. And out of that, the community mental health movement arose to try to deal with this problem, and that resulted in the Community Mental Health Act of 1964, followed by Medicare and Medicaid enacted in 1965. However, things didn't always keep getting better. If you recall, there was tremendous inflation in all segments of the economy, but particularly in medical care. And a commission from the Office of Management and Budget concluded that there were too many specialists who were ordering too many tests and all that sort of stuff. And so the Congress ended funding for medical education and specialty training, forcing the states to assume the cost. So there were fewer trainees funded, and many of the private psychiatric training facilities closed, stopped accepting new trainees. So there have been some recent developments that have been useful. In the 1990s, they saw the rapid closure of lucrative propriety hospitals amid scandals. And this has really been a kind of a blight on the scene, and I, for one, happy to have seen them go. There have been a substantial increase in dementias and developmentally related disorders, particularly autism and spectrum disorders, but also other developmentally related disorders like learning disabilities, and reasons we don't understand. There have been the emergence of much more effective and safer treatments, both pharmacologic and psychosocial, which have emerged during this period of time. And frankly, we are so much more effective in treating and even preventing significant mental illness than we had been when I started in treatment, my practice back in 1977. So this decade has seen the development of the psychiatry primary care collaborative model. And this is really something that we should be quite proud of. Dr. Jürgen Unitzer and Dr. Hilt, both part of the University of Washington program. Dr. Hilt's over at Seattle Children's, and I must say I worked for Dr. Hilt for 6 years toward the end of my career before I moved up here, actually including after I moved up here. And this is a really useful set of programs that have helped people out in the primary care field, both rurally and urbanly, take care of patients with mental health issues. And it's worth noting that people in primary care actually provide 75% of the medically related psychiatric care in the United States. So the COVID-19 pandemic has made things a lot worse. The social disruption, the isolation, the economic hardships have all increased the severity of mental illness and increased the rates of drug overdoses and suicides, as our President Gary frequently reminds us. However, not all is gloom and doom. There was Governor Inslee's initiative following the loss of the Medicare certification back in 2018, which covered a variety of ways of expanding the availability of psychiatric care in the communities. And the civil commitment patients were distributed out of, or are to be distributed out of the 2 state hospitals to community smaller units so they can be closer to their families and support systems. The initial funding for this was unfortunately $350 million. And I say unfortunately because in this next biennium, which would really be required to kind of carry through on this, this is all up in the air. Unfortunately, mental health issues are not very high in the priority list. We rate somewhere down close to care for the homeless. So there have been other positive developments. There have been long-standing, over the last 20, 25 years, expansion of geriatric programs to meet the increasing frequency of dementia. There's been a rapid development of the psychiatry primary care consultation model for rural communities throughout the country. And so these programs that Dr. Hilt and Dr. Unitzer created here in the Seattle area has really spread quite rapidly. So I think that that's a very good shift, because we're never going to be able to crank out enough folks to treat the problems. So there's been an emergence and adoption of telemedicine and internet therapies, and I think this is one of the good things actually about the pandemic, is that telemedicine is an issue that I have been recommending for people in practice for probably the last 5 or 6 years, and it's caught on pretty slowly until this year. I don't think it's going to go away. There's been an establishment of mental health and drug diversion courts, and I want to give a shout out to Judge Snyder for being involved in that. There's been a development of evidence-based mental health programs, particularly for suicide prevention, but also for anxiety and depression generally. Unfortunately, we don't have something like that here in Bellingham. There's been expansion with Obamacare. But I want to point out that at every step in history, we have done more and learned that that was not enough. But that's not a reason to get discouraged or give up. We must continue to move forward, deal with the issues as we see them now, and keep trying to improve things. So here, a quick rundown of things that we need to do. I realize I'm kind of running close to the end of my time. We need to further increase professionals for professional training and funding for mental health services. We need to develop appropriate programs and facilities at all levels of care. And I also think that there needs to be a greater coordination programs up and down the line, from intensive inpatient to outpatient programs and everything in between. There needs to be an expansion of funding for research to bring more young folks in. The situation now tends to discourage young researchers because they find it so hard to get grants. We need to overcome the stigma of mental illness and substance abuse addiction, because I want to point out that increasingly it's obvious that these are biologically related problems. I mean, you'll say, well, the choice to drink or use drugs is voluntary. But, once those things take hold, it becomes very much a biologically driven experience. So we need to improve medical insurance reimbursement, including Medicare and Medicaid, for mental health and substance abuse treatment to achieve true parity with medical and surgical treatment. We need to strengthen mental health prevention and early intervention efforts. And I think that this is an increasingly important thing to do in order to reduce the long-term burden of mental illness. And we need to, of course, expand the psychiatry primary care consultation programs that was started here. So these are some things that may be, some people may consider somewhat controversial. I think we need to modify the culture of police forces so that it can be seen as community safety organizations rather than primarily crime prevention response organizations. I think the police really need to do something to help win back the trust of all the segments of the population, which is certainly not true at this point, and particularly not in this junction of history. We also need to develop a mental health crisis response teams that can respond rapidly to volatile situations. And as Mayor Fleetwood noted last week, we now are creating the Grace's team, which hopefully will be able to supplement the police response. So that concludes my remarks. I thank you very much for giving us this opportunity, and I'd be happy to be available for any questions.
John, this is Paul.
Yes.
Do you think, with the lack of funding for Medicare, Medicaid, is there any real opportunity for a private solution to the problem? A for-profit?
I think unless there's increased funding for care in the private sector, I don't think that there's any possibility for a private sector solution.
Thank you.
Other questions? How about a big round of applause for John, an excellent program.
Thank you, thank you. Thank you for having me.
I don't know if Garrett's still on, but I'm gonna put on screen sharing for a second and see if I can grab my screen that I wanted to use. Okay, oops, that's not the right one. Hold on a second. I just lost it. Where did I go? Huh. That didn't work. Did I lose everybody? Can y'all see me?
Gary, I can see your screen, the current status,
Okay. You can just see me, or can you see the
graph.
You can see
Right.
the graph. Okay.
Yes.
I don't know why, but I have nothing on my screen at all showing up. But let me just give a quick report, and then I'll show the stuff on it that I wanted to call attention to. What I wanted to put up was just the current, as of this moment, what's available on the dashboard. Yeah, it says I'm screen sharing. Okay, it's over here. I can see where I'm at now. All right. And basically for the week, it's been mostly status quo with the exception of a rash of cases at one of the local nursing homes. And the deaths that occurred out of that nursing home all occurred outside of the hospital setting. So I don't know any of the details other than they were all reported as quite elderly, in their 90s or in their hundreds. And none of those patients, to my knowledge, came to the hospital. There is currently one patient in the hospital who will be discharged in the next day or so back to outside of the hospital, not expected to die. There have been no deaths at the hospital in the last week, which makes many weeks in a row that there have been no deaths in the hospital. And none of the patients in the last week required ICU level of care. The number of deaths have gone up since I reported to you last. All of those were, to my knowledge, related to deaths in the nursing home of people who are very old and had extensive comorbidities and do not resuscitate orders, and were not, none of them were transferred to the hospital. They all died in the nursing home setting. If you look at the COVID pages, I'm just going to run through them really quickly. The first one gives the number of cases. Remember, whenever you see the word confirmed, that you should be very skeptical because there's duplication of positive test results. If one person has had 10 different tests, all of which were positive, they'll count 10 times in this number.
Oh my.
The hospitalization numbers are closer to accurate, but when you ask the hospital, their numbers are lower than what's been reported here. The death numbers are also, I wouldn't say exaggerated is the right number, but they're counting people as deaths that had a positive test result, but did not die from the virus. Like, for example, I mentioned last week, a motorcycle fatality was the youngest person that's been attributed to our county. His death had nothing to do with COVID, but he had a positive test result on record, and therefore he got counted when vital records cross-linked the records to the number of deaths. At some point in time, I anticipate this number will again go down, as it did once before in the last few weeks when somebody actually reviews these cases. So if you look at other things, let's go to number 2. This looks at the age of the deaths. Notice that 36 of them were over age 80. This one down here that shows under age 40 is incorrect. That's our motorcycle fatality. So these numbers are both wrong. These numbers are closer to right, although I think if you looked on a case-by-case basis, a lot of people are being counted as having died with COVID rather than from COVID. These are hospitalization counts. You can look at them both by cases, hospitalizations, and deaths. So just wanted to show you how you can use this data to look at this data. This looks at confirmed cases, again, the word confirmed, positive test results by age groups and sex. And you can see that we have a substantial number of people that have tested positive in the 20 to 39 age range, but every single one of them have recovered. And this looks at the rate of testing, which has remained fairly steady, and our positive rate has actually dropped. And if you go down to look at the metrics, these are how we're doing over the week. The number of new cases per 100,000, we're not meeting goal. The percent of positive tests, we are meeting goal. The percentage of empty beds, we're not meeting goal. However, the number of people that are in beds at the hospital is substantially below. So what I will tell you is that these two combined tell you that we still have substantial capacity at the hospital and are not in danger of that. And then this looks at 7 and 14-day new diagnosed cases. When you put an arrow on it, you can see that for the week from September 24th to August 7th, there were 48 cases per 100,000. You can change that to hospitalizations and put the arrow over there, and you can see the number of people that were hospitalized. Going through this relatively quickly, but I just want to show how the information can be observed. Daily testing rate, and actually in the last one, also, if you clicked on the left side, you could see the percent of positive tests. See that the rate of positive tests is below that 2% level and is remaining quite constant over time. That's a good thing. This looks at the number of beds. The hospital is filling more beds with non-COVID patients, which means that the 20% goal of keeping the beds open is not being met, but we haven't been anywhere near full capacity since the hospital's been keeping open beds. So again, that's a good thing. And that's it. I'm gonna stop sharing there. If there are any questions, I have about 1 minute before 1:30 to try to answer a quick question.
Gary, what do you make of what appears to be a rapid recovery of the president from his COVID?
I think actually his recovery is fairly usual, actually. I think most people are sick for about a 1-day period, drop their fever after that day period, and then recover completely. Or they might have some minor lingering symptoms. The one that seems to be most common in my experience is loss of smell or taste. They haven't divulged whether or not he has any ongoing symptoms at all, but they haven't denied it either, which would lead me to believe that he may have something like decreased smell or taste. I think that he likely has antibodies developing, although I don't know whether they're high enough yet to be detected. So I think that the information that he's doing well is believable. And
the
I think
length of being
is believable.
and the length of being contagious?
We don't really know. if his antigen test result is negative, which is what I'm assuming they're basing the statements that he's no longer contagious, he probably is no longer contagious. That is our current understanding. And so if he's cleared the antigen, it would be my expectation that he's developing or has developed antibodies and is not contagious. I mean, I'm speculating based upon what's been released, but I think that's reasonable.
Yeah, President Gary, any thoughts as to why these deaths that have occurred at Highland long-term care facility, why those folks, as they became seriously ill, were not transferred to the hospital for more intensive care?
I think it's because they have do not resuscitate orders on their chart. And that means that when they got sick from anything, whether it be a urinary tract infection or E. coli food poisoning, they're not going to be treated and they're going to be allowed to expire in their residential setting at the nursing home. That's speculative, but that's been a consistent finding. I think a lot of elderly people, have been faced with what do you want to do if scenarios. And I think that as discussed when I was program chair, I think we do a pretty good job of finding out what their will is and that they're dying. Now, I do not know, and I do not have access to know whether or not those people actually died from COVID or whether they had a positive test result and died from their underlying comorbidities without any signs of infection. As everybody knows, not everybody with a positive test result is positive because there are false positives, and not everybody who is a true positive has symptoms. So if, for example, somebody was in the nursing home and was on hospice for end stage, let's say congestive heart failure, that COVID infection may or may not have contributed to their death, but they are being counted because they're test positive. Beyond that, I have no way without being able to review their individual charts to know if they actually died from the virus or not.
Thank you.
Okay, I'm over time. I want to very quickly thank all of the people that made this meeting possible. Sarah for helping Sandy and I greet, Jim Cunningham for AV, Arlie Norman as our Tatler reporter, Tom Grinstead as our editor, Debbie All for Minister of Fun, Rick Kaiser for doing the music, Steve Band for the invocation, Paul Gray as our program chair, Bruce Clausen for the book review, and John Dunne for a terrific program. Next week, our program is the district governor. Look forward to seeing everybody next week. Have a safe and healthy week, and thank you for being Rotarians. See you soon. We are adjourned.
Did you hear that?
I did hear that. Thanks, Andy. Bye, everybody.
Well, Gary, Jen and I have it set up. She's going to come by the house and pick up the